Good morning, everybody. I'm Kate Stenyam, and I'm the Program Manager for the Delta Region Community Health Systems Development Program. I just want to welcome everyone today and let you know the Delta Regional Authority and the Health Resources Service Administration's Federal Office of Rural Health Policy are the ones that are partnered to support this DRCHSD program. And through a cooperative agreement with the Federal Office of Rural Health Policy, the National Rural Health Resource Center, where we are located, administers the program and manages the provision of services to all of the selected hospitals and communities. So I want to thank you all for joining us today for this exciting educational opportunity. We have two exceptional trainers from BKD that are going to be leading this billing and coding boot camp. Through the DRCHSD consultations, many of you have already met Paula Archer. She is the director at BKD, and Marla Dunn will also be presenting over the next 2 days, and she is the managing consultant with BKD. A few reminders before I get things turned over to Zineva to go over some housekeeping. So following the training, BKD will provide a one-on-one coaching call with each organization, and that really helps to complete the training to resolve any specific coding and billing challenges you might be having at your organization. If you have not already done so, please coordinate this call time, this one-on-one coaching call time with your team, as there is only one call per organization. They won't be doing multiple calls per organization. If you have any questions, please contact Zineva Hackman, who is our program coordinator. I'm going to now turn things over to Zineva, and she is going to go over some housekeeping details before we go ahead and get started.
Good morning, everyone. So as Kate said, my name is Zineva Hackman. I am the program coordinator for the Delta Regional Community Health Systems Development Program with the National Rural Health Resource Center. I'd like to welcome you all today to part one of the BKD Billing Coding Bootcamp Hospital Focus Training. We're glad you could all take the time to be here with us today. So before we get started, I'm just going to go over a few housekeeping details. When you call in, your phone line will be muted. To unmute or remute your individual line, press *2. Once you call in, please keep your computer speakers on mute to avoid any echo or feedback. You can communicate via the chat box at any time, which is located on the left-hand side of the screen. We will go over any questions at the end of the presentation. The file share box, also located in the lower left corner of the webinar screen, contains a copy of today's webinar materials. When you click on the name of the file in the file share box, you can then click on the download button to download that file directly to your computer. Throughout the presentation, there will be polling questions that will be asked. The poll questions will be in a gray dialog box with a question. Please answer each question to the best of your knowledge. Thank you, and today's webinar will be recorded, and a link to the recording will be provided once it is uploaded to our website. Now I'd like to turn it over to our speaker, Paula Archer with BKD.
Good morning, everyone. Good morning. Can you hear me okay? Will you confirm that, please?
We can hear you.
Thank you. Good morning, everyone. It's good to be with you this morning, and we have a lot of information to cover. I'm grateful to the Delta team to allow us this opportunity to go over some coding and billing. I wouldn't say they're issues, but things that we can address during this session of things that we have identified to hopefully meet your needs and questions as organizations and rural hospitals. And we're just going to go ahead and get started. Our talking points for today, we're going to talk about the emergency department and charge capture opportunities, and then outpatient observation, charge capture. CPT coding, another hot topic, is documentation and capturing charges for infusions and injections. We're going to briefly talk about ICD-10 CM coding and where we're going from here with specificity with ICD-10 coding. And then we're also going to talk about just the provider-based clinics billing and billing the office visit code, the G043, and some compliance with billing that code. And then also we're going to touch on compliance and modifiers. I did add registration to this list today for talking points because it seems to be an ongoing problem for many organizations, registration and getting registration accurate on the front end to prevent any front-end denials for billers or others in the organization to have to work through. So we'll talk about that as well. So we'll just go ahead and get into ED charge capture. I think there's some confusion sometimes that we see versus the facility or the technical component of the ED evaluation and management services and capturing the levels of services for those codes, specifically 99281 through 99285, and then the professional component of those. So I want to briefly just go over the difference of the facility component reporting versus the professional coding, the differences between those. If you think back, the CPT code book, which is written and developed by the American Medical Association, its original intent was to be utilized by physicians. That under the new OPPS rules, CMS instructed, you think about it, and this is going to age several of us, not all of us. Back in 2000, new rules were established for OPPS reporting of facility component E&M levels. And CMS has instructed that the words in CPT for physician or provider that's supervised by the physician should now be omitted from the interpreting code descriptions. So now, according to CPT, a clinical staff member is a person who works under the supervision of the physician or other qualified health professional who is allowed by law and regulation by the facility policy to perform or assist in the performance of specified professional services. So for ED charge capture, it is appropriate to capture nursing interventions within the facility component of ED charge capture. So then again, nursing interventions and acuity levels. Many hospitals use an acuity level mapping criteria. This can either be based on a point system or interventions. We see it both ways. And also there is no correlation between the facility ED levels and the physician's levels of service. The professional fees are typically captured through the regular 1995 or 1997 CMS E&M guidelines. So either one of those is appropriate to capture the professional levels of service. But for the facility levels, CMS has instructed us and facilities to use their own acuity sheets or mapping tools. Again, no national guidelines have been published yet for the ED evaluation management services. And we are going to talk about the provider-based clinic and billing those evaluation and management services in the provider-based clinics later, as I just discussed. But for the ED, it's very different. And so CMS has actually given providers 11 principles to follow, and this is kind of on the compliance side, to follow when you're developing your ED acuity level criteria. And number one is that the coding guidelines need to follow the intent of the CPT code descriptions. And they have to be based on hospital facility resources. Again, this will be based on the nursing interventions performed in the ED. And the documentation of those interventions must be clearly identified. Number three, clear to facilitate accurate payments. And of course, always meet the HIPAA requirements. And in that required documentation that is necessary for patient care. Again, it's going to be imperative that your nursing staff and your ED document well for the services that they're providing. Number six, should not facilitate any upcoding and should be written and recorded and well documented. And this is, documentation is imperative for capturing the ED evaluation and management services for the hospital. And it should be applied consistently across patients, and it should not change with great frequency. It should be readily available for Medicare or Medicare administrative contractors to review, and it should result in coding decisions that could be verified by other hospital staff. So those are very specific 11 guidelines that CMS has given us and offered, and the reference here for these 11 guidelines are in the 2008 OPPS final rule. That's where you can find these documented, and nothing has been updated or changed since that time. And we do not know what the future holds. I anticipate that since the evaluation and management services for capturing office visits have changed on the facility side, we do anticipate in the future that the ED evaluation management services codes will also change. But for now, this is the rules that you need to abide by. And this, I've given you, I just mentioned back in 2007, this is when really the OPPS final rule, and I know that OPPS does not apply to critical access hospitals from a prospective payment system perspective, but it does apply when coding and meeting these ED facility guidelines. And so here it is in the Federal Register, April 7th of 2000. Each facility will be accountable for its own system for the different levels of HCPCS codes or CPT codes. So I also want to note there's the last sentence. It says, therefore, we would not expect to see a high degree of correlation between the code reported by the physician and that reported by the facility. However, keep in mind that the codes do not have to match. We already know that. So the facility resources may be higher or lower than the physician, but typically there could be some correlation between them, but they do not have to match. So I wanted to provide you with some graphs of some things that we have seen in facilities. For this is a facility ED charge capture, ED distribution for the facility for one hospital. Looks like a pretty good bell curve, and CMS does state that they anticipate seeing a very good bell curve distribution, especially with the rural hospital settings. If you'll note with this particular facility, it seems to, 99283 seems to be representing a pretty good bell curve, but we're a little bit higher on 99281 and 99282. Now that's not to say that that is a bad thing, but it is something that you would want to look at to see if your resources are truly matching the 99282 lower level on the left side. And then my question would be, hospitals, if you have a lot of 99281 low-level visits, those typically are nursing visits, and they are also typically not seen by a physician. So it's something to think about, to look at your charge capture and your levels, and maybe to do an internal audit on these cases to see what's going on and to see if there's opportunities to maybe improve your acuity level sheet and to document better for the services that you're performing in the ED. Also just want to bring to your attention that for patients that are left without being seen by the physician, Medicare typically does not want to see those billed as a low level. And I can provide you with some data and facts on that. In fact, I don't think I have provided that in this presentation, but I'll be happy to do that on our one-to-one calls or after this presentation has expired today. For this same facility that we just previously looked at, the distribution of the ER services, this is the professional for the same facility. This was what was being captured for the physicians. And again, very high on level 99282, which is a little surprising. So again, I would anticipate seeing a more bell curve distribution. And then for the professional physician reporting, again, I think it's interesting that the 99281, that very low level, is creeping up there to almost the 99285 highest level. So this would be an area to really look at to see if you are missing revenue for your professional fees, your ER professional fee, evaluation and management services. So this would be an area to really look at. I wanted to give you another perspective here. This is another facility. This is the ED distribution for this particular facility, and you will note there's no 99281s. And what's interesting to me is there's no 99285s. This facility is hovering strictly around the mid-level 99283. And so for patients that are admitted to the hospital through the ED, I would anticipate seeing some 99285 higher levels. And now, I just switched slides, and I don't know if you noticed it or not, but this is the professional distribution for the same facility. Now, I'm going to switch back real quickly. You'll see there's the facility, and here's the professional. And they're the very same, they match up completely. For this particular facility, they were using coding the same for the hospital facility component as they were the professional. So there may be some really good opportunities here to really dive in, take a deep dive into the coding and reporting of the acuity levels for the hospital, and then also how these are matching up for the professional levels. Again, we would not anticipate seeing these match completely, but there can be some correlation.
Did you want me to go back?
No.
Okay. The first polling question will be coming up then. If everyone would want to please respond to the polling question to the best of your knowledge. We'll give you a few more seconds to vote, and then I'll switch it right back to the PowerPoint. Back to you, Paula.
Thank you. We're going to flip into now to talk about outpatient observation, and I just want to start off by stating that there's some confusion. I say outpatient observation because strictly it is an outpatient level of care. We do see physicians that document when they're in their orders that admit to observation, which can be very confusing. But I want to recognize now and just state specifically that outpatient level of service is, observation is an outpatient level of service, not inpatient. And just for the sake of information for this webinar, I also would like to state that observation level of care it's not based on location in the hospital. It is based on the level of care that the patients are receiving. So my reference for the information that we'll cover for outpatient observation charge capture can be found there in the Medicare Claims Processing Manual, Chapter 4, and I hover around Section 290, and there's a lot of information that we'll speak to in this presentation, but it's a great reference to go back to for more definitive guidelines and a lot more information that I may cover in this presentation. But we typically see observation ordered for patients who present in the emergency department. And this is for patients that require monitoring or treatment. This monitoring or treatment is utilized by the physician to make a decision, basically to either admit that patient as an inpatient if they're going to meet the medical necessity guidelines, or either discharge or transfer that patient to another facility or to home. And for Medicare guidelines, we typically see that this decision by the physicians should be made within about 48 hours. And of course, we would anticipate the utilization review or case management team to help the physicians within this time period to help guide them in documenting medical necessity to either make a decision to admit the patient as inpatient within 48 hours or to discharge that patient. Reporting hours or the units of observation on the claim form should be reported under Revenue Code 762. Again, it's imperative to utilize the physician's order to make that decision. And then also, this gets very tricky for some facilities. Observation time begins at the time that coincides with the time that observation care is initiated. So I want to talk about that just a little bit. In some facilities, we find that observation time is beginning at the order entry of when that physician writes an order and there's an order entry. But typically what Medicare states is that really observation time begins when the nursing care, again, is documented that the patient is received on the floor or starts beginning utilizing the nurse's assessment and care begins. Again, it's not based on location. So observation care can even begin in the emergency room. If there are no beds for observation, that care can begin in the emergency room. Again, we're going to round to the nearest hour. And Medicare specifically states that standing orders following outpatient surgery are not recognized. So what we see here a lot of times is that a patient may have a scheduled outpatient surgery, and maybe the physician wants to hold the patient overnight, so they send them to observation. So that is not recognized by CMS. For cases like that, they need to hopefully hold the patient in recovery room. Medicare recognizes 4 to 6 hours of recovery to be billed, and then extended recovery can also be billed in these situations. And then there are situations where the patient may be held in outpatient in a bed, and we can speak to that more clearly if you have questions about that in our one-on-one training. observation hours cannot be billed according to Medicare concurrently with diagnostic or therapeutic services. And these are those which require active monitoring. And again, you can go to the CMS guidance that I provided as a reference that has information on all of this. So what this means specifically is that if the patient is receiving maybe a physical therapy evaluation while in observation, well, this would mean that a CPT code for physical therapy evaluation would also be billed, and typically that's a time-based code which can be up to an hour. And so it would make sense that observation, that time for that diagnostic physical therapy evaluation would be backed out of the observation time. And also, just think about this. You might want to do a study on your observation hours to see if you do have observation hours that are greater than 48. It may be that you're overstating your observation hours, and you should be backing out time for diagnostic or therapeutic services. And when I'm talking about therapeutic services, this could be active monitoring of certain IV fluids. I'm thinking specifically about maybe some Lasix that requires active monitoring. Hydration infusions would not typically be included in this, but we can talk about that in our one-on-one sessions. Be happy to talk about that further. Hospitals should be deducting the average length of time of the interrupting procedure from the total duration a patient receives observation services. So it could be that the patient goes to radiology for a CT scan. It could be that the patient has an upper endoscopy procedure or other GI procedure. And we can talk about this again further during our one-on-one sessions that we have after this presentation. And then observation time ends on the direction of a physician order. We need to specify here that all necessary services up until the patient is discharged. So when the nurse has discontinued all therapeutic diagnostic services, that is when the patient is ready to be discharged, and that is when the observation time ends. So patient convenience will not be included in this time, and I think this is pretty standard, and I think most facilities do understand that you would not include time waiting for transportation home or for family members to show up and get the patient. I do want to speak to this. There is a comprehensive APC 8011, and this is for the prospective payment system hospitals, not for the critical access hospitals. This is the way PPS hospitals are paid for observation services. It's very different. So I just want to bring to your attention for PPS hospitals that may be listening to us today. I know that we do have some rural PPS hospitals within our Delta revenue cycle assessments, and just want to state that this is very different. A clinic visit with the G0463 or level 4 or 5 ED visit code, the 99284, or the high level 99285, or a level 5 type B ED visit. And I don't know that I've seen any type B ED visits in our revenue cycle assessments previously. And also a direct referral for observation, and that means a direct referral from the physician's office to the hospital for observation. These additional services will be bundled into one APC payment, and this is a comprehensive APC 8011, and will only be paid one rate. And again, this does not apply to critical access hospitals, and I'm happy to address any questions on this later if applicable to you and you have any questions on this. So these are the observation challenges that we've seen in our revenue cycle assessments and when we are interviewing revenue cycle departments. Challenges are that all patients should be placed in observation until reviewed. Getting that workflow created can be sometimes difficult and challenging. And then we see that observation start time is a challenge. If you think about it, some of these challenges will sometimes lead to manual entry of these charges rather than order entry, which causes a lot of issues, and we do understand that for many hospitals. Also, we have found that charging for injections and infusions are very challenging for hospitals during observation services. We do understand that nursing, clinical staff do not always document well for infusion stop times, and so this can be challenging. Again, it is a challenge, but it needs to be addressed if it's occurring in your hospital. It needs to be addressed, and education needs to be provided to the clinicians about the importance of documenting the infusion start and stop times. Billing for patients with greater than 48 hours of observation. Again, if you do some data analyses within your facility and you have greater than 48 hours of observation, again, want to make sure that you're backing out time for diagnostic and therapeutic services. And also, it could mean that you need to work with your utilization review and case management staff to better monitor these outpatient observation encounters. Separately monitored procedures, actual times versus a policy. Medicare says it's okay to take maybe some procedures, and I'm thinking what you could do in your facility. What I would do if I was in a facility is I would take my top 10 procedures for my patients in observation, and I would apply an average time for those procedures in order to back out the actual time. And then I would also create a policy for policy considerations. And again, I want to state that observation is not a place, it is a level of care. And here we go. I think this sets us up very well for the coding of infusions and injections. What we see sometimes in some hospital settings is that really infusions and injections are not being captured very well. We've actually seen some coders in hospitals that are not coding outside of, let's see, the 6999 series. And so therefore, infusions and injections are flying by the wayside. If this is happening within your organization, we do recommend that you hire a charge capture specialist that knows and is trained on capturing infusions and injections and on the hierarchy of these infusions and injections. But we're going to talk a lot about the definitions of these to start off. And this is strictly CPT coding. An infusion is defined as any substance infused through any type of line that is greater than 15 minutes and then up to 1 hour. And it's very important to watch the time in these descriptions to accurately capture infusion and injection charges. An IVP push is an infusion of 15 minutes or less, or an injection in which the clinician that administers that substance or drug is continuously present. I think about this as a nurse that is doing an IVP push into a line, and of course that nurse is continuously present during that time. An injection is an intramuscular, subcutaneous, or intra-arterial injection. Very different. And there is always one initial code in each category based on the primary reason for the encounter. We want to also specify that only one initial code can be reported by encounter, no matter how many drugs are administered.
All right, Paula, if you're done with this slide, I'll pull up the second polling question now. If everyone would please participate in this one as well, thank you. In a few more seconds, I'll switch it back over to the PowerPoint if anyone wants to respond one more time. All right, thanks everyone for voting. Back to the PowerPoint. Back to you, Paula.
Thank you. I would like to say that was an interesting polling question, and honestly, it really depends upon whether you're a PPS hospital or a critical access hospital. It looks like the majority of the attendees of this presentation got that right, so that's really good. It depends upon whether you're a PPS hospital or critical access hospital and how you bill outpatient observation services. So we will continue to talk about infusions and injections. And Delta team, are we going to allow questions during this presentation, or are we going to wait until the end of the presentation?
I believe we're going to wait till the end of the presentation, but if people want to put their questions into the chat box, we can for sure make sure to get back to those at the end of it.
Okay, thank you.
Yep, thank you.
So we're going to talk now about infusions and injections just a little bit further. And so what constitutes that a continuous infusion was provided? So in this specific scenario, if a continuous service was provided, you would report all the units as performed on the date the service started. For continuous services that last beyond midnight, now this is tricky for many hospitals, and they ask this question, or hospitals ask us this question quite often. For continuous services that last beyond midnight, you will use the date on which the service began and report the total units of time provided continuously. And so here's an example of that. If an intravenous hydration, as described by these CPT codes, 96360 and the additional 96361, the additional hours, is given from 11 p.m., let's think about this, to 2 a.m., then that initial code, 96360, would be reported once for that first hour, and then the additional hour code, 96361, would be reported twice, 11, 12, 1, 2. You see how that's 3 hours, and that makes sense, right? The first hour would be reported once, and then 96361 would be reported twice for those 3 hours. And was the infusion discontinued? What do you do in the case that it is discontinued? In CPT states, and here's some examples, any disruption in service that creates a new initial service, that is going to be a discontinued infusion. For example, here we go. A patient receives 1 hour long drug infusions starting at 10 p.m. and 2 a.m. on sequential dates. So no new IV is started, and the same drug is infused each time. In this example, because the infusion is not a continuous service, code 96365 would be reported once for each date of service. And I hope this makes sense. If not, we can definitely have more conversations about this. I'm happy to do that and provide additional information. Medicare, in its publication, the Medicare Claims Processing Manual, Chapter 4, and this is Section 230.2b, for facilities, it states that drug administration services are to be reported with a line item date of service. So this is going to be billing, right? A line item date of service on the day they are provided. In addition, we reiterate the initial drug. Only one initial drug administration service is to be reported per vascular access site per encounter, and that includes including during an encounter where observation services span more than 1 calendar day. So that's going to back up what we just stated about how to report and capture the infusions and injections. And again, this is Medicare Claims Processing Manual, Chapter 4. I hope that you will visit this and use it as a reference moving forward. There are documentation requirements for infusions and injections. You know, I put this on here. It's clear indication of the patient name, date of birth, and the date of the service. That needs to be on every page in the documentation of the medical record. But for infusions and injections specifically, the name of the drug injected needs to be documented by the nurse. The dosage of the injection that is given needs to be documented, and the route of the administration in order to capture that appropriately. And of course, a signed and dated physician order that will include the drug name, the dosage, route of administration, and the duration of the treatment. Those are things that Medicare and other payers will be looking for, specifically Medicare, for compliance with billing and reporting infusions and injections. And of course, the progress notes should support the medical necessity of those services. And I put here just a reminder. We see this oftentimes in facilities when certain injection procedures, like an epidural steroid injections, also require documentation of previous conservative therapies that were tried and failed. And I also want to mention that I know that many facilities, if the stop time is not documented in the record, the nursing stop time is not documented, that many facilities will downcode to an injection. And we're going to talk about that in the next few slides. Start and stop times matter, and I hope that you can see this. I hope it's not too small for you. And I don't know that I can make it larger, but I'm hoping that if I'm seeing it, you can see it as well. But Medicare does not provide specific guidance on should or should not be reported for start and stop times. And providers should check to see if their Medicare administrative contractor has a policy about this, and if so, follow it. So if your MAC has no policy on this, then adhering to CPT guidelines is the most appropriate course of action. So therefore, if you don't have a documented stop time, then it would be appropriate to downcode to an injection. And, you know, I've been looking for some MAC policies on this. I know that WPS had a policy several years ago. I have not been able to find any updates. If you have, I would love to know that and would love to chat about that after this presentation. MACs have their own guidelines for reporting infusions without documented stop times. And again, the CPT manual indicates an IV push can be reported. You know, some people say that infusion can be reported only if it can be determined from the documentation that that service was more than 15 minutes in length. So here's where we have some differences. The American Medical Association recommends that providers document start and stop times, but does not say this documentation is required. There is no statement about stop times being required. However, it's implied that it's the best practice to ensure appropriate billing. And I'll go a step further. It's also the best practice to ensure appropriate reimbursement. Many times that infusion time will generate more revenue than merely an injection. So the hospital, if your nurses are not documenting stop times appropriately, then you may be missing revenue. So again, we're going to talk about the Medicare Claims Processing Manual, Chapter 4. Codes should be reported in accordance with CPT guidelines. CPT instructions are to use the actual time over which the infusion is administered to the beneficiary for time-specific drug administration codes. So I want to talk about hydration. Hydration is defined as replacement of necessary fluids during IV infusion. And it consists of prepackaged fluids and electrolytes. And here's a listing of some solutions that would be considered administration of hydration services. Saline, dextrose, D5W, hypotonic solutions, lactated ringers, and distilled water. And this reference for hydration, what those solutions are, is comes from Coding Clinic for HCPCS. I hope that many of you have access or subscription to Coding Clinic through the American Hospital Association, and it is a wonderful subscription. I hope that you all have access to Coding Clinic through your coding encoders. But this came from Coding Clinic for HCPCS first quarter 2012, page 1. Hydration, of course, 96361 up to 1 hour, that's that initial code that we talked about, and then each additional hours is reported with 96361. Any services that are less than 30 minutes will not be reported based on this time-based description. The hydration codes were created to report specific therapeutic interventions. And so what is expected is, for medical necessity purposes, is that the physician have documentation that the patient is dehydrated, experiencing volume loss, that is requiring the administration of hydration fluid. It should be clearly documented in the record. We have noted that some hospitals are experiencing hydration denials, hydration services denials of those two codes, because possibly the physician did not document in the record the medical necessity of dehydration or volume loss. And if the physician didn't document it, then that code would not be coded by HIM. The ICD-10 code wouldn't. And so some MACs are denying those cases due to lack of medical necessity. So you might want to take a look to see if your hospital is receiving any denials for hydration services based on the lack of medical necessity. The following infusion circumstances do not represent hydration and should not be reported using a CPT code. And this is when the purpose of the infusion is to accommodate an IV piggyback through the same access or free-flowing IV to safely infuse the agent, or when the fluid was used as a diluent to mix the drug. For example, the fluid is the vehicle in which the drug is administered. And here's something we often see. This is wanting to highlight this and underline it. When the fluid is used just to merely keep a vein open, the IV line prior or subsequent to another infusion. And then also when IV fluids are allowed to continue to run during the administration of a chemotherapy or therapeutic agent. All right, we're going to switch over to ICD-10 CM coding a little bit. We're going to focus a little bit of our time on this. Does everybody remember October the 1st of 2015? I remember going through ICD-10 training courses. Everyone was trying to get up to speed. And if you think about it, I remember when January 1, I'm thinking some of you remember as well, of 2000, Y2K, we thought the world was just going to end. The day the earth, just would stand still, everything would break loose. And we were kind of thinking that about ICD-10 when it became effective October 1 of 2015. So we're going into 4 years of ICD-10, and from what we're seeing, we're still here and we're still doing good, and hospitals are reporting well. I think that probably the only problems or issues that hospitals may be having is getting the level of specificity from physician documentation to code appropriately. But want to just talk quickly about some things that are different in ICD-10 coding than ICD-9, and I would think some of these are good things. These are good differences, I think. And assumed causal relationships in ICD-10. The term with in ICD-10 now defined as a causal relationship. And so previously, the physician had to link a condition such as hypertension and congestive heart failure. And so the causal relationship changing in ICD-10 has really helped decrease the number of queries that coders have had to go back and request from the physicians to actually link conditions in order to code them appropriately. So this is a good thing in ICD-10. I want to really focus in on reporting additional diagnoses. This is not the principal diagnosis, this is additional diagnoses. And so many times the physician may be documenting in the discharge summary a condition that wasn't even addressed anywhere else in the documentation. And we see this happen quite often. That I want to specify that these other diagnoses, ICD-10 specifically states that to be reported, these additional diagnoses must affect clinical evaluation, therapeutic treatment of the patient, any diagnostic procedures that the patient may have incurred for these additional diagnoses. They typically would extend hospital resources or the length of stay, and they typically would require increased nursing care or monitoring. So be very careful in reporting additional diagnoses and be sure that they are meeting the ICD-10 coding description of reporting those specific conditions. So here's some other additional guidelines that I'll refer you to. If a previous condition is documented in the discharge summary, like we were just talking about, that has no bearing on the current stay, it should not be coded unless it's hospital policy. I don't know that if you have any policies on this, but if you do, I would certainly go back and be really careful and be very specific about that and why you may be coding those conditions. When I see a statement like that, I'm thinking about maybe to capture nicotine abuse or conditions such as that nature. So be sure and look at your hospital coding policies if you have those to make sure that you are being compliant with reporting additional diagnoses. And then abnormal findings such as lab, x-ray, pathology, and other diagnostic tests are not coded unless the provider documents the clinical significance. And then uncertain diagnoses documented as probable, suspected, likely, questionable, possible, or still needs to be ruled out are coded as if they exist or they were established. And then I put a note here. I want to be certain that you understand that this guidance that is right here on this slide does not pertain to coding in the outpatient setting. This is for inpatient coding. I want to clarify that. Respiratory failure sequencing, we're going to just cover some of these quickly. These are just problems that we see when we're doing, when we're visiting coding departments and issues for reporting respiratory failure. If both the respiratory failure and another acute condition are both present on admission and both equally responsible for the admission, the guidelines regarding 2 or more diagnoses that equally meet the definition for principal diagnosis may be applied. So meaning that if the patient comes in with respiratory failure and has another acute condition, maybe, let's say, cardiac atrial fibrillation or congestive heart failure, then you could report either respiratory failure or the atrial fibrillation as the principal diagnosis. But you have to make sure the documentation will indicate that both of these conditions are present on admission and both equally are responsible for that admission. SIRS continues to be a very complicated coding decision for many coders. And so now I just want to inform the audience that Medicare is now looking at clinical manifestations that should be documented in medical records to come to a diagnosis of septicemia or the systemic inflammatory response syndrome. And then according to the American College of Chest Physicians, here's some good clinical manifestations that you can look for when you want to query physicians about septicemia or the SIRS diagnosis, and that is fever of greater than 100.4, leukocytosis, white blood cell counts of greater than 12,000. So coders can be looking for these conditions within the medical record to query physicians. Tachycardia, and then also hyperventilation. SIRS, when documented with a non-infectious disease condition, the code for the underlying condition, such as an injury, should be assigned, followed by the code R65.10. And there's 2 codes for SIRS. There's one, R6510 without organ dysfunction, and then R6511 with organ dysfunction. I want to talk a little bit about body mass index. Now I think I need to get rolling here on these slides, so we'll pick it up a little bit. Code assignment for body mass index in the depth of non-pressure ulcers, and this also applies to pressure ulcer stages and the coma scales. Code assignment may be based on medical record documentation from clinicians who are not the patient's provider. So this means that nursing staff can document, and you can code from the body mass index the depth of the pressure ulcers and pressure ulcer stages. But please note that last sentence, associated diagnoses such as the patient being overweight, obese, and the fact the patient does have a pressure ulcer, it must be confirmed by the provider. Malnutrition, I want to bring this up because I know that many rural hospitals probably have patients that are malnourished. Many of your patients come from nursing homes, and we do understand that. But malnutrition is a focus of the Office of Inspector General, so I want to bring this to your attention. Specifically, these are ICD-10 codes 261 and 262, and I want you to understand that you must have documentation consisting of meeting the definition of additional diagnoses that we just talked about on those previous slides. And I gave you a resource, a link here at the bottom of this slide to look at a malnutrition toolkit. Medicare and the OIG are really looking at this closely. So again, looking at clinical pathways, documentation of physicians, of how they're treating malnutrition should be documented, and again, follow the additional diagnoses coding that we just spoke about. The OIG has recognized, and many hospitals are putting into place and using what we call the Aspen Guidelines. These are clinical pathways to help guide a coder in whether to properly code for malnourishment. And so typically we see patients that are nutritionally at risk, that either involuntary loss of 10% or more of their body weight within the past 6 months, or they've gained 10 pounds within 6 months, their body mass index has decreased or increased, they have metabolic requirements that need to be addressed, altered diets or diet schedules. So these are some things to look for before you start reporting malnourishment. So, are you ready for ICD-10 or ICD-11? I was really surprised, and this is very recent, March 2019 of this year. If you are receiving any American Health Information Management associations, publications, CodeWright just published that ICD-11 is coming, and I put a statement here that came specifically out of this publication. There have been many advancements, and we know this, in medicine and the science of disease over the past 30 years. ICD-10 now is outdated. Well, who would have thought, from both a clinical and classification perspective. So the decision was made in 2007 to already begin working on ICD-11. So we don't know when ICD-11 is coming, but want to put this on your radar that AHIMA is publicizing information on this, and so we can, of course, all look forward to this in the future, ICD-11.
All right, I'll pull up poll number 3 now. If everyone would please vote. A few more seconds to put your vote in before I switch over to the PowerPoint. All right, thank you. I'll put it back to the PowerPoint. There you go, Paula.
Thank you. want to talk about the provider-based clinic for a moment, and specifically the HCPCS code G0463, and I want everyone to have a good understanding on how to report this HCPCS code for office visits on the facility side. So it's effective in 2014. This HCPCS code was developed. Is specifically for hospital outpatient clinic visit for the assessment and management of a patient. And it's to be reported by hospitals to represent a clinic visit provided under the OPPS. But additionally, no longer will CMS recognize the distinction of new or established patient clinic visits. And this is for facility reporting. So under the OPPS, all clinic visits will be reported utilizing the new HCPCS G code, and that's G0463, regardless of whether or not the patient has been registered as an inpatient or outpatient of the hospital within the last 3 years. So a few changes with that beginning in 2014. Now for critical access hospitals, what Medicare stated is critical access hospitals may bill the new G code for clinic visits, and that's a facility service, but you're not required to. That Medicare has no edits that would prevent a critical access hospital from being paid if you went ahead and billed the regular evaluation management codes for the new and then versus the established patients. But your payment would also not be affected if you are paid at reasonable cost. So for physician services rendered in a Method 2 critical access hospital during a clinic visit, the Medicare fee-for-service coding, which are the CPT codes, would be used. And if that's going to create some confusion, we can certainly talk about that. The Medicare Benefit Policy Manual, and this is in Chapter 6, it defines a hospital technical visit as a hospital outpatient encounter in which there's a direct personal contact between the patient and a physician or other person, here we go, other person who is authorized by state licensure law and is applicable by law, hospital or critical access hospital bylaws to order or furnish hospital services for diagnosis or treatment of the patient. So that goes back to the CPT guidelines about the physician or other authorized individual healthcare provider. So a clinic visit code should not be automatically charged, and I want to really specify this strongly. A clinic visit, this G0463, should not automatically be charged whenever the patient sees a nurse or other member of the hospital staff. According to Medicare's Transmittal A 0180, hospitals can charge a separate clinic visit code, this code with Modifier 25, only if a significant separately identifiable technical visit is performed during the same encounter as another service or treatment. If there is a significant separately identifiable visit, Modifier 25 would be reported with this code, G0463, and complete documentation. This is key right here. Complete documentation of all of those services performed needs to ensure that the patient encounters and procedures on the same day are correctly reimbursed. So again, documentation of a separately identifiable evaluation and management service is key in order to report this HCPCS code and Modifier 25 appropriately and to get reimbursed for it. So, you know, really, honestly, compliance is embedded in all of this presentation, but we're going to talk about compliance just briefly here for a moment. The OIG has developed a series of voluntary compliance program guidance documents, and I wanted you to be aware of the links below this slide that you can refer back to as far as to the compliance program guidance that the OIG has documented. Many hospitals use this guidance for their own internal compliance procedures and processes. And specifically, this guidance was published on February 23rd of 1998, and it has not been updated since. So just want you to know what it says. While it may require significant additional resources or reallocation of existing resources to implement an effective compliance program, the OIG believes that the long-term benefits of implementing the program outweighs the costs. So I wanted you to be aware of what this guidance states. And then the OIG also gives 7 elements that would be included in a good compliance program, and that would be the commitment to compliance, to have a compliance officer, to have regular education and training programs for employees, and the maintenance of a process or hotline to receive complaints. It will, again, this will all be dependent upon your hospital and what your needs would be to meet these elements. The use of audits or other techniques to monitor compliance, and investigation and remediation of any identified problems. And here's some areas of concern that is documented in the program guidance. Billing of services not provided. This should be of no surprise to any of us. Providing medically unnecessary services, upcoding, duplicate billing, unbundling services. I think specifically of lab procedures for unbundling, that's an example. And billing for discharge in lieu of a patient's transfer.
All right, I'll pull up the last polling question. If everyone would please put your vote in. I'll leave it open for a few more seconds before I switch it back to the PowerPoint. All right, switching it back to the PowerPoint now. There you go, Paula.
Thank you. I just want to specify that ABNs will be discussed further by Marla during her training sessions tomorrow and Friday, and she'll be able to provide some really good information to you on ABNs and medical necessity. I put this red pepper on this page because I love the color red, and we're also going to be talking about the pepper, the program for evaluating payment patterns, electronic report. If you're not aware of this, you can find through this web link, pepper.org. You can find more information about pepper. I think pepper is a good way to kind of look at your all compliance areas, specifically regarding your DRGs, your readmissions in your hospital, the way you're reporting your principal diagnoses, and whether you're an outlier. You can either be an outlier or you may be under-reporting some things. But the pepper does provide hospital-specific stats, your hospitals, for Medicare MSDRGs and discharges that may be at risk. And pepper can support a hospital's compliance efforts by pinpointing where the institution, where your facility may be an outlier for other identified risks. The pepper also includes target areas outside of the MSDRG reporting. Specifically, I'm thinking about critical access hospitals for this particular case, but it can also target 30-day readmissions. The 3-day skilled nursing facility qualifying admissions, one-day medical stays, one-day surgical stays, and now even emergency department evaluation and management visits. It's a good way to look to see where you may have some upcoding or some undercoding in some cases. So be sure, and if you're not, identify first who in your facility is receiving the PEPR reports, and then identify who needs to be receiving them. So many times we see that hospitals are not really reviewing those, and we think they're a good resource for compliance. I also want to talk a little bit about excisional debridement real quickly, and this is outpatient specifically. From a compliance perspective, and these specifically are CPT codes 11042 through 11047. And reporting these codes is based on the deepest layer of viable tissue removed. I know that many of our rural hospitals have wound care centers, outpatient wound care facilities, provider-based many times. So I wanted to bring this to your attention. In order to code and report excisional debridement, outpatient excisional debridement, the wound length, width, and depth must be documented. The type of the debridement, whether it's excisional or non-excisional, should be documented. The cutting away of devitalized tissue, typically this is going to be necrotic tissue, it should be documented. The instrument that was used, whether it was a scalpel or scissors, should also be documented, and then after that, the depth to which the wound was debrided, from the skin all the way to the bone, that should be documented as well. So some final thoughts, keep current. I'm just thinking about the things we've gone over. We're not through yet, but wanted you to keep current on the CMS instructions for detailed billing and potential payment issues. You can do this, and I know that many of you are doing it through your MAC listservs and newsletters. Provide ongoing training for your internal staff training on billing and coding guideline changes. I think many of you are doing that as you're also maintaining your charge masters. Monitor provider documentation and compliance with the service criteria, whether that's wound care or hyperbaric oxygen services. Perform internal testing of your claim forms, your detailed billing, coding, and provider documentation during routine compliance audits. So I told you we would talk about registration when I was talking to the Delta team, and many of you that I have seen previously and even that I'm going to see here in the future, and I look forward to seeing you all. We just want to talk about, there's so many opportunities to get it right in the registration areas, and even to collect. So this is so important. I don't know if we have registration people on this call, but I just want to reiterate what we state in many of our assessments and when we're having conversations with you within the facilities. You've got to obtain a complete and accurate patient information. That's just going to be imperative to get it right the first time and then to be able to collect. And this is demographic information. This is the correct insurance, the correct medical information, and notify the patient of any copays that are due and collect on those. And investigate other potential coverage sources. Do they have any outstanding balances? Go ahead and investigate that then. But it's just imperative for registration staff to get this information accurate on the front end. Many times when we are looking at aging accounts, they're sitting maybe in the 120 or greater than 160 days. It's because typically registration was not, the correct insurance was not determined on the front end. And then the billers are having to track and go through numerous attempts to bill the right payer. And of course, payers are always looking to not pay us, right? So you can hit untimely filing limits due to not getting the registration information up front as accurately as possible. So there are some metrics and best practice targets for registration that we just want you to be aware of. And we do understand that some of this is going to come from the departments, not necessarily from the registration staff, but that physician authorization needs to be compliant and complete at 95% compliance. Inpatient admissions error ratio, it should be less than 3% error rate. Outpatient registration error ratios should be less than 3%. And here we go. Many of you have policies in place on collections. And I have met some of you that have collecting 50% up front, and this is a best practice. Point of service collections, the best practice is to collect 50% of the estimated patient portion at that place of service or that point of service. Very important to do that. The percentage of pre-registered inpatient accounts should be 40%, and outpatient accounts should be 20%. When I was looking at questions that you were submitting to our Delta team, I noticed that some of you had requested information on modifier usage, and I just tagged this on to the end of this presentation. So I want to cover modifier usage guidelines. And of course, modifier usage will, in terms of reporting, we're going to be talking about the outpatient setting. And just want to give you some tips on how to report modifiers. That not all procedure codes require modifiers. The use of modifiers eliminates the appearance of the unbundling and duplicate billing. And not appropriate, modifier is not appropriate if the narrative description of a procedure, that's a CPT procedure, if the narrative description applies to different body parts or indicates multiple occurrences. Modifier usage, they indicate special circumstances, and many of them are reimbursement modifiers, so it's really important to report modifiers appropriately for compliance concerns because modifiers many times will affect reimbursement. And we talked briefly previously about modifier 25 and appending that on a separately identifiable evaluation and management service. We want to just reiterate here that only reported with the evaluation and management service when that same physician on the same day performed a diagnostic medical or surgical and a therapeutic medical or surgical procedure on the same day. Modifier 52, this is an important modifier. It identified interrupted or reduced radiology exams or other diagnostic services. And you would code to the extent that a procedure is performed. And we can talk more about that later. But you code to the extent that a procedure is performed. And when I think about procedures in which an interrupted service occurs, I think specifically about colonoscopies. That's what I'm thinking about specifically in this scenario. But if no code exists, you report the intended code, and that's a CPT procedure code. But it cannot, modifier 52 cannot be submitted with evaluation management services, only procedures. So here is an example. The patient, if a patient is scheduled for a GI series, and that's CPT 74240, and the radiology exam could not be completed because the patient could not tolerate maybe the barium, then this is how that procedure would be reported with modifier 52. That's just an example. And then we also have modifier 73. This is important to identify procedures that are discontinued or canceled after the patient has been prepared for surgery. and or prior to the induction of anesthesia. So that's key right there. It's discontinued or canceled prior to the induction of the anesthesia. So this modifier is only applied to procedures that require anesthesia. And it's only applied when the well-being of the patient is threatened, and that should be documented specifically by the surgeon. And the procedure must be discontinued in that room where the procedure was to be performed in order to assign that modifier. So reimbursement would be discounted, of course, when you append the modifier 73 appropriately based on the appropriate service lines and what is happening to that patient prior to anesthesia and whether that patient was in the room. Modifier 74 is a little bit different. This is when a procedure is discontinued or canceled, but it's after the administration of the anesthesia, not before, but after the administration of anesthesia. Again, applied when the well-being of the patient is threatened, and then the procedure, again, would be discontinued in the room for which the procedure was to be performed, whether that's the GI suite or the operating room. And this information, again, if you have access to the American Health Information Management Association's audio seminar series, this came, honestly, from 2008. It's very applicable. Nothing has changed. So this is just good, really good information to have. I have given you a little kind of a workflow on when to report modifiers 52, 73, and 74. And this will help guide you, your coders, on when to appropriately report these three modifiers. It's just a little guide here and a worksheet process flow. I want to talk also about modifier 59. This is an unbundling modifier. It is a reimbursement modifier. The OIG and Medicare, they are really scrutinizing the use of modifier 59. It does prevent improper payments when the incorrect code combinations are reported. And then Medicare does have the MCCI edits that they bump up against to make sure that hospitals are complying and reporting modifier 59 appropriately. And those edits can be found in that link at the bottom of the slide. Then we have modifiers left, right, and 50. And again, I hope that you will be able to use this material as a resource for you in your coding and documentation efforts. The left and right modifiers, they identify procedures that can be performed on paired organs. So when you think about the paired organs, that would be the eyes. So when you have a cataract surgery, you have it first on the left eye, and then later on you go back in, and the patient comes in for the right eye. And it's very important to append these modifiers appropriately because Medicare can see, oh, this patient had a cataract surgery 3 months ago, and now they're having another one. If you don't identify which eye is which eye is receiving the cataract surgery, then Medicare may deny your claims for not appending the left and right modifiers. Left and right modifiers are only appended when a procedure is performed on only one side of the body. Again, like for the eyes, the cataract surgeries. Modifier 50 is a little different. It's going to tell Medicare on your claims that a bilateral procedure was performed during the same operation session. And then modifier 50 is only for paired organs. And here's the key right here. Modifier 50 is not going to be reported with CPT procedures when the description of CPT indicates that the procedure is unilateral or bilateral or multiple occurrences. So there's some guidance where left, right, and 50 can sometimes be very confusing. Now we're going into questions. I'm seeing some things, some chats that are being documented. Delta team, can we open it up to some questions?
Yep. Just a reminder, *2 to unmute your line to ask questions, or the chat box is also available. If you put a question in, I will read it out as well. The other question was just on how to get to the material, which is in the Files 2 box below. All you need to do is click on the slides, the Day 1 Delta grant slides, and then download file, and that way you can get the PowerPoint. It looks like Deidre Criswell is typing right now in the chat box.
Thank you, Deidre. I would really welcome some questions, and I don't profess to know all the answers today, but I will certainly attempt. And Marla is on the line with us too today, Marla Dunn, who will be presenting to you tomorrow from a rural health clinic coding and billing perspective tomorrow and Friday. I hope that you will be able to join her. But even from a rural health clinic perspective, some of the information that has been presented today, do you have any questions for me or Marla? Please let us know.
And just a reminder, *2 to unmute your line if you'd like to vocalize your question, or you can go ahead and type it in the chat box. I'd really encourage you guys to take advantage of asking some questions right now. You have an expert on the line here available to answer your real specific questions. So just would encourage you, if you have anything to ask her, if you're thinking of a question, it's most likely that several other people on this call are also thinking of the same question.
I would really, if you could unmute your lines, I would love to hear from you directly and personally rather than in a chat box. That would be just really awesome. I know that I may not have covered, even if there's something that you have that you would like to ask a question about that was not covered in this presentation, we would really welcome any questions that you might have. And we do understand that we could not cover everything today based on hospital coding and billing, because there are so many nuances and so many of you have different nuances that are going on within your individual hospitals.
Okay, so yep, I'll read out that first question for you here, Paula. So a question from Deidre: if an ED physician does diagnostic testing and also does IND or other procedure on abscess, do we apply Modifier 25?
That is a great question from a facility perspective for facility reporting. If the physician is doing some diagnostic testing and then lo and behold the patient is coming in and being seen and evaluated for maybe a cyst, and the physician does go ahead and incise and drain that cyst, then yes, he would report that office visit with Modifier 25 or the ED level, the ED service with Modifier 25. That would be appropriate. Thank you for that question.
And then the next question from Brandy: what was the difference in reporting observation time depending on type of hospital?
Yes, and that's a great question. I'm glad that you remembered to circle back, Brandy, with that question. For PTS hospitals, the observation time units will be rolled onto the inpatient claim. So only an inpatient claim would be reported to Medicare. For critical access hospitals, you would report an outpatient UB04 with bill type 131 separately, and also then you could report your inpatient stay separately. So there's two very distinct differences. The PPS hospital, because of the 72-hour rule, would roll the observation encounter information into one inpatient claim, but critical access hospitals, when the patient is admitted, will report two different claims, one for the outpatient observation on bill type 131, and then the inpatient UBO4 claim form bill type 111. I hope that answered your question. You're very welcome. Thank you. Those are great questions. Surely we may have more. Does anybody have any questions regarding the Office for the Provider-Based Clinics reporting that HCPCS code for the evaluation and management? Do you have any questions on when to report that, when it's compliant or when not to? If you do, I'd love to address those questions as well, because I know that many of you have provider-based clinics, again, for pain management, wound care. Would love to address any questions you might have regarding that, if you have any.
And just a reminder, it's *2 to unmute your line. I see another question coming up in the chat box.
Hi, Kim. You're very welcome. Glad you could join us today. I see we have 35 participants. I recognize many of these names, and so glad that some of you that I've already met are joining us, and some of you I will meet, and look forward to that. Any more questions? Now, I've been talking for almost an hour and a half. It's okay. I would love to hear from you verbally if you would like to ask a question. And it can be any question. It can even relate to revenue cycle topics that we have covered previously. My colleague Marla is on the line. Marla, can you think of anything that I may have missed that you would like to address? Not to put you on the spot, but I would like to tell our audience today that on our BKD website, I'm going to go back this way, this direction, right there at www.bkd.com. You can sign up right here for our ThoughtWare and subscribe, and well, there it is again, bkd.com/subscribe, and you will identify many articles that we have written that pertain to revenue cycle, all kinds of billing scenarios, nursing homes, swing bed information, 340B information. There's a lot of information that can be at your fingertips if you would like to go in and subscribe to our BKD ThoughtWare. Marla and I have written white pages and articles here as well. I see there is a question about registration metrics and what is our source for our best practices and our registration metrics. And our sources come from HFMA's Key Performance Indicators, KPIs, MAP keys. We also get information from good resources out of HIMSS, and these are the metrics that we recommend and best practices that we see also in other facilities.
There was another question that came through from Sarah. Do we report 96372 and 96374 together? Will it cause a denial?
You know what, that's a great question. I saw that, and I'm looking in my CPT book right now. And you can report those together. Now, you may need a modifier, and I'm happy to address that further, but it depends upon the circumstances. Of course, you would report the 96372 as the initial service, and then you would report the 96374 as an additional IVD push. You are able to do that. Now, I'm thinking you might need a modifier 59, but I would have to check my NCCI edits. Does that answer your question, Sarah? Thank you. Those are great questions. Are there any additional questions? We've got time, and I would love to spend this time addressing anything that you may have. Again, even outside of this presentation.
We had another question from Vicki Allen. Will swing bed claims be discussed at some point during the training?
Hi, Vicki. That's a great question, and we can certainly address that during our one-on-one time. I hope that you will sign up for that, and we will certainly address swing bed claims for you during that time. We'd be happy to. Thank you. That's a good question. And I'm guessing that that would be the billing of those swing bed claims, but we will talk further about swing bed claims in our one-on-one training.
Looks like we have another question coming in.
Very good.
Okay, question, should we report 96372 for each drug J code that is billed, or only one injection per drug?
You would want to report each drug that the physician orders and that the patient receives. You would report the administration, the 96372. I'm looking at this. It could be, for example, I'm thinking about if the patient receives an intramuscular antibiotic, and then you would report the 96372 for the administration of the antibiotic and the appropriate J code for the antibiotic. And then if the patient receives another substance or drug outside of that, then you would report, again, 96372. You could report that times 2 units, and then you would also want to report the individual J codes for the drugs that were administered. I hope that helps. Very good. Thank you for that question.
Another question, is it appropriate to use a 91 modifier for CCI edits on labs? I hope I said that right.
You did, and that is a great question. We did not cover Modifier 91. And Modifier 91 is specifically used on laboratory CPT codes. And typically this is when the physician orders a repeat lab service. 91 is for repeat lab. Sometimes a physician may order, I'm just guessing, I'm creating a scenario here, maybe pre-operatively a blood count, and then post-operatively may order another one to see if the patient was becoming anemic after the surgery. So in that case, the CPT code 85025 for the white blood count would be reported on the claim twice, and the second line item would have Modifier 91 appended to it. Does that help answer your question? Great, thank you. That's a good question.
From Karen, so that would be reported on 2 lines instead of 2 units?
Yes, I would report that one line for one day, and it should be the same day. Keep in mind that this should be the same day that it's repeated. And then you can report it on the second line with Modifier 91 to indicate to Medicare that you are reporting that twice. And the reason you're reporting that twice on line item 2 is, in opinion 91, is that it's a repeat procedure on the same day. Does that help?
Okay, another question. Yep. Should a 59 modifier be appended to 96372 each time it is reported with a drug /J code?
I'm going to say not necessarily, and I'm going to say that because I would need to know more information, and we would have to understand our NCCI edits. I know that many times Modifier 59 is necessary, but it depends upon the circumstances of the drug administration, how that is occurring. I'm reading your question too. Each time it is reported with a drug J code in a clinic. You know, I think that Marla can cover this question, but I don't think Marla, my Delta team, if you're listening, I don't think Marla, I think she's tried to unmute a couple of times, but isn't able to be heard. I haven't been able to hear her. I don't know if that can be helped on this call to help her become unmuted so that she can address the clinic setting.
Yeah, Marla, if you are on the line, just press *2 and you should be able to unmute your line.
Okay, can you hear me now?
We sure can.
Oh, there we go. I have tried many ways to unmute. I appreciate that help. Hello, everyone. Let me go back and look at this question. Again, Paula is correct. Even in the clinic setting, if you're doing some clinic infusion, you do have to pay attention to what you're infusing, how you're infusing, and when you're switching drugs. There are going to be circumstances where that 59 is required. In the clinic setting, if you have an office visit on the same day of service as an infusion service, you would not append the 59. Really, that office visit will either stand alone with no modification because really that infusion is not a professional service, although it may be going in on your clinic claim. For example, if it's a freestanding clinic and everything is going out on the 1500 claim form, if that office visit is over and above that work that's for the infusion, then they would append a 25 because that's two separate services on that same day. And not the 59. As Paula was saying, the 59 will be appropriate if there's some type of edit that requires you to apply that 59. And also, yes, it's usually used when you're switching drugs. Also, if you have to switch sites, if there's an occasion where you have to stick the patient in different sites, in different arms, that can sometimes also be a reason why you would want to use a 59. So it just depends on the scenario and what you're infusing or pushing.
Very good. I hope that helped. And yes, this would apply in the clinic setting as well as an office visit. You're very welcome.
And I guess we could take that a step further, Paula, if they are, it wasn't really defined what type of clinic, but for example, if it is a, let's use rheumatology as or an oncology practice as an example in the provider-based setting where that clinic is really looked at as an extension or a department of the hospital, you know, you're going to want to be splitting those services, particularly for Medicare. Where they want that technical service, which is, all, again, your nursing service, that infusion, the drugs, all of those infusion and push codes, that would all go on the facility claim. And just the professional evaluation and management service or anything that that physician did or the non-physician practitioner did, face-to-face, hands-on, that's the only thing that would go on that 1500 claim. Oh, in the RHC. Interesting. You're doing infusion in the RHC? That's unusual in that setting just because of the cost of the drugs. Not infusions. Oh, Sharon, I like the way you spell your name. That's really cool. Oh, injections, just pure drug administration. Yeah, we are going to be talking about that over the next 2 days with the RHC training. But since you are asking, in the RHC setting, the rules for drug administration are a little bit different for your primary Medicare and primary Medicaid patients. In the RHC setting, it's going to depend on when that administration is done, whether it's a drug administration or a vaccine. So if you have excuse me, if you have a situation, sorry about that, got a tickle in my throat. If you have a situation where the physician or the non-physician practitioner has already come in to see the patient, they've had their medical E&M service or their preventive, let's say maybe a child is in for their routine annual physical, and they've asked the nurse to come in and give their vaccines, all of your charges for those drugs or vaccines, as well as the administration, is put on that same UB04 or the claim form to Medicare or to Medicaid, depending on whether you're using a UB or a 1500 to primary Medicare or Medicaid. I'm so sorry, getting my payers confused there. UB04 to Medicare, either a UB or a 1500 to Medicaid, depending on your where your hospital is located. So if it is administered during that visit with that physician or non-physician practitioner, then those charges are all added onto that same claim form, and you are paid under that encounter rate. For both Medicare and primary state Medicaid, if that patient comes in to just see the nurse, let's say the doctor ordered them to come back for maybe an additional round of vaccines that they didn't give during that first visit, then that is considered part of a nurse-only service, and that cannot be sent out on a claim form to either Medicare or Medicaid. Those are considered nurse-only services, and nurses are not considered core providers in the RHC setting. So for those two payers, you track that information in your system, but you don't generate a claim. So you basically adjust that off so that a claim is not generated. And then those types of services, supplies, et cetera, are tracked for your cost report. Your accounting cost report preparer will ask for that type of information at the end of the year, and then that is settled at the end of the year for more on a cost payment versus that encounter rate. So you have to pay attention to where are your nurses and when are they doing